the survey operations side of Accreditation Commission for Healthcare, or ACHC. And so essentially I do a lot of these webinars, trainings for partnerships, state associations, to go to conferences, meet with a lot of clients, do kind of client one-on-one trainings as well with consultants. And then I am one of the managers for our surveyors, so our surveyors that do home health deemed programs, HIT, home care side of our programs, all of our community space. And so today, we're going to talk about top survey deficiencies. My understanding is everyone on the call today is kind of more administrative geared. And so we're going to talk more about the back office stuff, so to speak, that we see with our surveys among our clients. So I did pull deficiencies that are relative to our requirements, but you'll see these things in the industry no matter who you're with or going through a survey with. And so we will talk a little bit that integrates to the patient out record, just because one of the couple of things I did pull, I think, are a little more administrative or back office type issues that we see than, you know, in relation to the actual hands-on services of the patient care. So also I wanted to make sure, Leslie, you can see my screen okay?
I could.
It says I was sharing it, but I just want to make sure.
Let's do it again. Yep, I can see it.
Okay.
Everybody good? Feel free, this is not a huge group, so if you have questions during the session, feel free to include them in the chat. I'll interrupt Becky if needed. Yeah, great. Perfect.
All right, so we'll go ahead and get started. So our objectives here for the training is we are going to understand the recent survey trends and survey deficiencies. Like I said, I've pulled the top 10 is what I pulled in the last about 12 months that we've seen among peers. And this is nationwide, so this isn't necessarily going to be specific to Massachusetts, but you know, it's nice to see what other things are going on in the country. We're going to recognize key documentation and evidence required by the surveyors that our surveyors are going to review in terms of the requirement. So I'll go over the requirement and then we'll talk about what the surveyor actually reviews. And then talk about how to apply best practices or kind of tips for compliance in order to be in compliance with the particular requirement or regulation. So some things I do just like to remind everyone, because even though we may have home care agencies on here too, but home health, it's a good reminder to know that we do have different levels of deficiencies that we deal with in home health. And this is because Medicare tags more patient care related requirements as more severe. And so when you're going through a survey, or even when you're prepping through a survey, it's important to know which tags have a higher weight to them than ones that are just going to be kind of cited at a standard level deficiency. So the way Medicare structures it is they have standard level deficiencies, which are going to be your non-COP requirements. So these would be things like on a state level you would have to follow, or with an accrediting body. So if you're with a certain AO, you know, they have their own set of standards that they want you to adhere to. So anything that's cited during a survey on that type of level is considered a standard level, because there's no G tags, there's no Medicare requirements built into those. The individual G tags are also cited at a standard level. So when you are doing Medicare and you get cited at one of those G tag, you know, that they assign for the COP, then that's also cited at a standard level. And so these are issues that are not severe. They're usually individualized. They may be like affecting one area versus multiple areas. So like when we do look at, let's say, chart audits, it may affect one chart versus 10 of them. There are also oftentimes random issues that are caught. So it may not necessarily be a trend. It may just be something that didn't get done for whatever, had some sort of oversight. Versus a systemic issue or a systemic problem, which is what leads us into a condition level. So a condition level results when you have multiple things out under one condition requirement. And I'll show you an example here in the next slide, but this is where we see then multiple of the CMSG tags out under a single requirement or a single condition, they call it. And more importantly, if they are level 1 tags. So Medicare does identify which level 1 tags are. And those are the ones, like I said, that are typically related to patient care, things that would possibly be putting the patient in jeopardy if it was not completed or was not completed correctly. And so we'll take a look at what those are. We're not really going to focus on a lot of those today because, again, we're focusing more on the administrative type back office stuff as far as top deficiencies. So your level 1 tags typically run into the patient care aspect in the clinical record itself. So when you look at a standard, when CMS has them in the state operations manual, they have a number to them. And so here's an example of a whole standard. A whole standard here would be the comprehensive assessment. For those of you that do admissions, or you're very well the comprehensive, there's a lot of moving parts. There's a lot of pages to it and information that's collected. And this particular requirement with Medicare, you have different parts of it, such as the initial encounter, so the actual nurse going to the home and doing that initial visit. Then there's the completion of the paperwork. Then there's the need to make sure that the content of the comprehensive assessment is all encompassing, it's completed in its entirety. And then any updates as the patient's, progresses or degresses. So those are all this A, B, C, D, those are all subparts to one condition. And that one condition is the comprehensive assessment in its entirety. So if you were to be out multiple things under, let's say, the A, B, C parts, those are going to then add up to make possibly you being elevated to a condition level. If you were just having an issue, let's say, with the comprehensive or the initial assessment, let's say it wasn't completed on time or within that time frame that Medicare sets for us, then that's going to be cited at that single individual standard level or individual G tag. So it's important that when you're looking or doing your own internal audits, if you're seeing multiple issues out under one regulation or one condition, that you put some kind of action plan into place to fix those, because that's where you're going to start running into jeopardy of possibly being elevated. And essentially what Medicare says is when you do get a condition level, it doesn't matter if you get 1 or you get 10, we have to make a revisit to your location. So we have to come back physically on site. You can't just write a plan of correction for it. Standard levels you can, but for a condition, we have to actually physically come on site and make sure you have abated that condition. And so that's what we're going back for, is to make sure you fix that issue. So here are the level 1 tags that CMS gives us. And they did change back in April. They kind of renumbered some things. They also added and removed some level tags. We used to have level 1 and 2. They have now since removed level 2. So now it's just level 1 tags. And this is all the ones they identify as the high priorities. So these are the ones you absolutely want to avoid during survey. And as you can see, a lot of it, like I said, it has to do with the patient care. And so the good bulk of that, I'd say first 2/3 of this page is going to be patient care related. Now, when you start to get into like emergency preparedness, your organization admin of services, that's going to be more of the administrative side. So that's going to be making sure you have a plan as far as emergency preparedness goes. The organization is going to look a lot at, admin oversight, making sure that there is oversight of the day-to-day operations of the business. So really, there's just a few of the level tags in relation to the actual administrative or governance of the agency. So when we're looking at our top home health deficiencies, so we mentioned this is based on previous surveys from the last 12 months. This is all deficiencies that are the most cited administratively. If I were to pull top deficiencies overall, what we see in any surveys, you're going to see different ones, because that's going to be all the patient care stuff. So it's going to be things like with the POC and the comprehensive assessment. So today, though, we're going to focus on what we see the top administratively, and we'll go into each one of them, but it's going to be things like contracts, the OASIS in particular to Medicare, hiring documentation. So a lot of things with the personnel record, whether that be hiring documentation, photo ID, CPR, skills competencies for your staff that actually go and do the actual care on the patients. TB testing is a big one, but especially buzzing around right now. Direct observation visits, which is where someone is actually going to the home with a clinician and actually seeing the care being performed in person. And then things like the financial consent and the patient rights. So those are things here again, they're tied to the clinical record, but a lot of that stuff is done on a back office type of situation for most agencies because they're filling out that consent ahead of time. And the clinician is likely going there and explaining the consent once they arrive and do that admission. Patient rights, that's going to be, a matter of making sure your patient rights statement is up to date, but then you're also getting the patient to acknowledge and sign that they received a copy. So I did include just kind of in parentheses, even though these are all going to be, except the OASIS can also be transparent in the home care. So if you are a non-Medicare agency on the call, then these all can still apply. These all are still things that you will need to be having involvement in. But I did throw the particular G tags that we see cited in relation to these requirements. So we'll look at the requirement as a whole, but it's important to know that some of these do have G tags tied to them, because if they were to be cited, you would get cited at that Medicare G tag standard level. And then the red just indicates that these are identified as the level 1 priority tags by CMS. All right, so our first area is just organization and administration. So here we see, there is a requirement to have an agreement in place. If you are going to use outside resources or outside personnel, these would be either independent contractors, or let's say you're contracting with a group. Let's say maybe you're going to contract with a therapy group that's going to supply therapists in order for them to see your patients. Essentially, you need to have an agreement in place. You need to have some kind of agreement or contract that's in writing with either that or other organization that is going to supply these individuals, or that individual itself if they are doing as an independent contractor. So making sure you have a written agreement in place one way or another. The agreement needs to specify certain things, and so I'll show you things that have to be in there that Medicare requires. But making sure essentially those components are there in writing, being mindful of, it's nice when you can use your own contract because you can kind of assure that. But if you're having someone that's coming to the table with a written agreement, you still need to look that agreement over. Don't assume that all these components are included in there when you go to sign that agreement. You need to make sure that they are encompassing. So if not, then you need to look at, well, do you want to use your agreement, or can we draft up an addendum to that written contract so these components are inclusive? So you need to have a mechanism in place to indicate that you are reviewing or renewing these written agreements when they come to term. So your contract should have a notion in it, how long that contract or agreement is good for. Let's say it's good for a year, and then when that year comes due, you're either going to have them sign or re-sign a new contract, or you're going to make some kind of notation saying, this contract is still valid and it's going to continue. So something that can indicate to the surveyor that you did indeed review it from the time that, it was per the terms when it was originally signed, but that it's going to continue on if you are not going to have them re-sign a complete new one. So something to indicate that there was that review. If there's updates that need to be made, obviously, then you'll want to update the contract and have them sign a new one, or at least have them sign an addendum to indicate that that review was done as well. So for Medicare, these are their requirements. They require this verbiage to be in the written agreement. So they want you to acknowledge that the person you are coming under contract or under services for arrangement for that they have not been denied Medicare or Medicaid enrollment. And so that's where you're going to need to do not only have this verbiage in check, but you'll also want to check for that through things like the OIG, making sure that they're not being on the OIG exclusion list, making sure that they haven't been excluded or terminated from any other federal health program or Medicaid. So your Medicaids is going to be on your state level. So making sure there are no any bans, and there are typically multiple Medicaid programs in the state. So it's not just checking that traditional Medicaid. It's also maybe checking those med waiver programs. Making sure that they have not had their billing privileges revoked. So maybe they were billing at one time, but for whatever reason, more times than not, it's related fraud. That they didn't have their billing privileges actually revoked, or that they've been debarred from participating in a government program. So here, a lot of checking of that with the OIG is going to, ensure that when you are checking those names, oftentimes there's similar names out there. So just verifying that that is that individual. You don't want to prevent someone trying to provide services on your behalf as the agency if you didn't do and you had the mix up of the names. So make sure that you do verify that. And then the agency has to ensure that all services being furnished are being done so under arrangement provided by other entities or individuals, that they meet the requirements of Section 1861W of the Act. And so this actual verbiage has to literally be in the contract in order to meet the intent. Now, from an AO perspective, there's additional things we require. So you would need to look at your AO if you're with a different accrediting body to see, but these are pretty typical in the industry of things that we also want to see in the agreement. So things outlined like that, the patient is only going to be accepted or admitted by the agency. They're only going to be the one to bill the patient, so the third party or the contracted entity, they're not going to send any billing. Their process is essentially to bill the agency an invoice and get paid that way, and the agency is billing the client or the insurance provider accordingly. So it's just them acknowledging that they're not going to submit any billing claims to the patient or insurance directly. It also identifies the care services that are going to be furnished. So this is very important if you're contracting with another company, like we talked about a therapy group. Okay, they're going to be providing therapy. What type of therapy? Is it just PT? Is it PT/OT speech? Do they also have social workers maybe that they're able to provide? So outlining all the services that they are able to offer. They need to conform. They need to acknowledge in their agreement that they are going to conform with all of your agency's policies, to include things like background checks, meeting any qualifications in order to fill those positions, any skills competency evaluation, and supervising of their staff as necessary. They need to be involved in participating in the plan of care, care coordination. What is your process as far as when they have to submit clinical and progress notes? If you have a certain policy or time frame on that, they're acknowledging that they're going to meet all of those requirements, just as an employee of your agency would. And then what is the procedures for them to be reimbursed for their services? Oftentimes there's going to be rates in that contract as far as what you've talked about, negotiated, and agreed upon as far as how those services will be paid, the duration of the agreement, the requirements that they're going to meet the Medicare COPs, because even though they're a contractor, they're seeing patients on the agency, you as a home health agency's behalf, or home care. And then supervision of the personnel we talked about. So that would maybe up to you as the agency. Do you want to take over that supervision and supervise them, or do you want to leave that up to the managing entity? Oftentimes, if you're using an independent contractor, then you're probably going to leave the supervision with you as the agency, so just making sure that it's getting done. One thing we also see with contracts is who's going to be responsible for the upkeep of that personnel record for those individuals. We, for example, don't require those personnel files to be kept into the the agency's office. But more times than not, we get there for survey and we want to see a contractor's file, and they're not able to get it within the time frame that we're there from the contracting entity or individual. So that's just one thing to also keep in mind when you write up your agreements or renew them. How is that going to be handled? Because if we can't view that information, we're having to cite the agency for, the information not being present or missing or outdated, anything like that. The responsibility still lies on you as the home health or home care agency. So making sure that if you are going to have the contractor be solely responsible, that they are reliable and you can get access to that fairly quickly. And then access to liability insurance. So you would need to have proof that they have liability insurance as far as coverage for that individual or that entity. So tips for written agreements would be, ensure you have a written agreement to begin with. You can't have anybody supplying services to your patients without that agreement in place, whether that be an individual or another organization. This could also be a staffing company. If you have staffing companies like in your area that are supplying nurses or aides, let's say, make sure you have a written agreement with those components in there. Make sure the written agreement contains all the required elements. So the two essentially required elements that Medicare requires, and then anything that your accrediting body may have as far as additional requirements. And then make sure there's evidence that either the agreement was renewed, if it was time for renewal, or at least was reviewed as far as still being valid. Something that can show the surveyor that it was indeed reviewed. So something has to be in documented writing. All right, the next one then is Oasis transmission. So this would not be applicable to home care. We do see this applicable to Medicare agencies. Some Medicaids are, wanting to see that Oasis. So really it'd be up to each of those programs on whether they wanted the data collected and they want it, or if they want it transmitted as well. So you would just have to get with those individual insurance payers on their requirements because they're all different. But for Medicare, we know we have to collect the OASIS. And so the requirement is that you're going to collect the OASIS. You have policies that govern the OASIS. You're going to ensure that the OASIS is accurate. So some things we see on the patient record side is just making sure that that OASIS is reflective of the patient status at the time that it was collected. But here from an admin side, it's making sure that it's collected period, it's sent timely. So it's transmitted through the means that Medicare requires. So we know we use the Medicare iKey system. So making sure that you're staying up to date with if they ever change that, the way it has to be transmitted, but then making sure you are transmitting it in a form within that 30 days. So Medicare does require 30 days of completing from the time that the assessment was completed on the beneficiary. And so make sure like I said, the OASIS data is coded correctly. They are using the correct assessment. There's different versions of the OASIS assessment tool. So making sure we're using the appropriate tool for the appropriate time. All right. So then as far as tips, ensure that it was each OASIS was completed. It was encoded. Hopefully, most of you on here are using an EMR system. So really that does that for you. You're just kind of exporting that file, which then you take that file and electronically transmit it to CMS's system. So it has to be for each beneficiary with respect to the information that is being transmitted. As a reminder, OASIS needs to be collected on any non-maternity, Medicare, traditional, and HMO, and Medicaid, traditional and HMO patients that are 18 and over that are receiving skilled services. So a lot of agencies choose to just do OASIS across the board for all their patients. Then they're not having to kind of keep up with who needs an OASIS and who doesn't. That's fine. but you don't need to transmit for those ones that it's not required. And you don't want to, because that's going to affect your scores when you do transmit it. That gets calculated in your quality reporting. So you really just want to focus on the ones that it's required to be reportable. So again, non-maternity, over the age of 18, Medicare and Medicaid patients getting skilled services. So we wouldn't want to collect OASIS for non-skilled services, people that are receiving just personal care services, because really that OASIS is a skilled assessment. It's geared towards skilled care. You want to check your transmission error codes. So when you are transmitting OASIS, you get those OASIS validation reports back. Make sure you're looking at those reports. On those reports, one thing we do look for is whether you transmitted over that 30-day requirement. So if you're seeing the error code, this -3330, that's the error code we look for during the survey. We're looking to see if that error code is populating. It's telling us that you had at least one or more OASIS that were not submitted in time. And it only takes one. It only takes one finding for us to cite it as a deficiency. CMS says that we are to cite it no matter if it happens 1 or 10 times. It still has to be documented as a deficiency. So make sure that if you are submitting those OASIS, you're getting that error code. Again, you want to educate your staff on the need for the timeliness of submitting the assessment, but then put some kind of education or action plan in your QAPI to be able to fix that, and how, thinking of strategies on way to how you can get those transmitted in a timely manner. And then ensure the encoded OASIS accurately reflects the patient's status. So when that clinician, whoever's doing that admission or the OASIS gets submitted, you have your people that do your billing and all of that, but you should really be having someone clinically that's going behind that OASIS, that's QAing that and making sure through a fine-tuned comb, not only that those MOO questions are filled out correctly, but it is accurate and it paints the picture of the patient's status at the time of that assessment. If it's not accurate, then if you go to do another OASIS later down the road, whether it be the same clinician or different, it may not show the quality of care that you are providing. Because if you painted them as not as sick at the time of the assessment and they didn't make any, or it doesn't show they made any improvements, then you're kind of shorting yourself there. So you want to show that quality data. So make sure you accurately paint that picture of the status. All right, now a good bulk of these are going to be the personnel records. So we're going to talk about human resource management. So the first starts with the hiring documentation. So hiring documentation, a couple of these things are on a federal requirement. So they're not necessarily something CMS has a tag for, because it's already a federal employment requirement. So for our standard, we require that the prior to or the time of hire of personnel, that they fill out a position or a job application. They have a signed and stated and signed withholding statement. So those are going to be for your employees. Those are going to be those W-4s that they fill out if they're ones that get a W-2 at the end of the tax year. For independent contractors, you're probably having them sign a W-9. But this is focused just on employees right now. So employees, you would need to have job application, the W-4 statement filled, and then the I-9 form, which is going to verify their eligibility to work in the US as a legal means. So making sure that those are in place before they even go see patients, before they start their orientation, you need to have those. So some things we see with these is usually maybe the job positions missing. Making sure you have a job position or job application is completed. So sometimes that's missing. Sometimes the withholding statement or the I-9 form is missing, but a lot of times if you're doing that because you're payroll, you have it. So oftentimes it's you're using an outdated form or the form is incomplete. So make sure the withholding statement, the I-9 and all of those are present at the time of hire. the W-4, that gets a new version every year. So make sure you're using the most current version of the year we're in that you hired the employee. For the I-9, that usually goes a couple years that it expires, but it does expire. So you do need to make sure that you're using the most current version. Right now, the most current version expires in 2027. So May 31st of 2027. So make sure you are using that version because that's something you could be cited on. Now, sometimes the government is late in issuing a version. Once it has expired, like I know in years past, the I-9 did expire, but they didn't come out with a new version yet. So in that case, obviously you can use that version until they do release it, but you need to stay up to make sure when those get updated because they will give you deadlines or timeframes of when you need to start implementing that by. If you're in a state where you have to do like e-verify, make sure you're, following that. But with the I-9, it's also, making sure it's complete. So whatever supporting documents that you're verifying for that work eligibility, then you need to have those supporting documents, evidence in place in the file. So making sure, based on those columns that you're verifying, if you're having one in column 1A or one from B and one from C, then make sure you do have those present as that you did verify that. All right, another one we see is with the photo identification. So our standards require you to issue a photo ID badge that your staff are going to wear. More importantly, this is with the clinical staff, so the staff that do go and see the patients. This is incorporated into our rights acknowledgement. So it is a patient right that you would let them know that they have the ability to, have these rights. But where we see it is on the honoring part. So are they honoring these rights? So we'll talk about the rights statement here later, but they need to have the ability to honor those. And the way we assess this is during that home visit. So when we go to the home with your clinicians, we're going to look that they're honoring their right to treat the person with respect and their property. But one of the highest heavenly cited things is wearing the photo ID badge. So when your personnel go to the home, they need to have the ability that the patient or the family can identify that, yes, that person is the person that's on that picture. That is their name that they told me because, this is, especially if it's the first time they're going to the home, they need to be able to identify this person actually does come from the agency. So it's a patient safety issue in that regard. So making sure that your staff have received an agency photo ID, making sure they wear it during the survey. It's a silly survey at times that we see agencies cited for it. But the fact of the matter is they need to be wearing it because it is a patient safety issue. So making sure that they have a photo ID that they can wear during the patient visits. So it needs to be agency generated in the sense that it should have, the agency's name on it or information. The agency is providing it to them. So that's really something that should be getting provided at orientation. It should be a part of that onboarding process is them getting some sort of photo ID. It should have their name listed. And then as well as like their discipline. Are they an RN? Are they a PT? Who are they that are coming from the agency? And so make sure they have it, make sure they haven't lost it. If they need a new one, what is that process to get that requested and issued? And then making sure that they wear it when they do the patient home visits, not only when we're there, but any home visits that they're having that interaction with. Now, office staff, that's totally different. That's up to you how you guys want to handle photo ID badges. If they're not ones that are making patient visits, then that's something that we're not going to necessarily require or cite you on, but definitely the clinical staff. All right, CPR certification. So this is a different one in the sense that we don't require CPR unless your state or you as an agency are going to require it. So really, we leave it up to you. So CPR may be different though with some other AOs. You need to see if they do require it. But in all honesty, as a nurse, I don't even have to have CPR certification. Um, as a nurse, I don't currently because I don't practice patient care. So it really comes down to most times than not the agency policy. So knowing what your policy says in relation to CPR is important, especially if you have purchased policies or maybe you've worked with a consultant and they've written policies for you. You need to know what your policy says. If your state requires it, then obviously that needs to be in your policy and we're going to hold you to that. But for most states out there, it's not. It's not a requirement in the actual regulations. It's not a requirement from CMS. So knowing what your policy says in relation to, do your clinicians, do your staff need to be CPR certified? So that's step one. If they do, or if that's what you want of your staff, then obviously they need to move forward with obtaining and maintaining a CPR certification. Our standards do say if that is going to be required of your staff, then online CPR certification solely is not acceptable. They can do the didactic or actual classroom part online, but when it comes to the skills verification competency, that should be done in person. And so making sure that you are aware and that then on the personnel record, if you're requiring CPR, that there is CPR present in the personnel record and it's up to date. So we know it needs to be renewed every few years. So making sure it does get updated when it comes time for renewal. There's also a little caveat that we have that you're going to notify your patients regarding your agency's policy as far as resuscitation and access to 911 services. So that's something you can have as part of that admission or welcome packet or booklet that you give your patients and family when you admit them. So tips here is again, verify what your policy states. If you don't know what your policy states, how do you know how to follow it? So making sure that you verify that. If you want to change your policy, that's fine. If there's things you want to change after today that we've talked about, as long as you're not going against, a CMS requirement or a state reg or your AO, then you're more than welcome to change and do a revision of that policy. Just make sure you update it. You run it through your governing body to get approval, and you have an effective date, and then you educate staff on that change. So these are things you may want to assess after the call today. If your personnel then do have to have CPR, which we say appropriate personnel is usually the clinicians, the direct care staff, then make sure it's current and make sure that when they do have to renew it, that they renew it and they give you a new copy. And so you're maintaining that copy of that proof in the file. Can't just show it to you at a time of hire that they had CPR certification and then now 5 years later, it's still the old one in the file. You have to stay up with it and maintain it, just like a lot of the other documents in the personnel record. Ensure that it wasn't an online CPR course. So I know there's some ones out there that they try to solely do online. Nope, it has to be evidence or proof that they did do it in skills verification. And then ensure that patients are receiving as part of your information that you provide them regarding your agency policies around resuscitation. Skills competency. So here we see, we need to make sure that the direct care staff that are going to see our patients have been trained in what they're going to provide, but also that they're competency in it. Just because they learned at nursing school, if they haven't done it in 5 years, they may not still be competent in it. So that's validating those skills before we send them out there on their own. So for skills competency, we require you to design some sort of competency program in the sense where you're creating documents. You're creating a form or assessment for each discipline or service that you offer. So a competency, let's say for an aide, is not going to look the same as one for a nurse. So make sure you do have one for each of the disciplines. These do need to be completed when you first hire them, prior to them performing a new task. So let's say maybe you didn't have that task at the time that they were onboarded, but they now are about to accept a new patient with that task. And so you need to competency them before they start seeing that patient independently. And then annually, we want to make sure that their skills are being competencied annually, because here again, there are some skills and they may not be performing on a regular basis. Therefore, we still need to validate that they're still able to do so. So competency assessments we allow to be done through multitude of different ways. So things like clinical observations, skills lab. So you can set up a skills lab if you want. You can do a verbal for a lot of these things with especially your professional staff, like your nurses and your therapists. If you want to have them verbalize how they would do a certain skill or do an assessment, you can do these through suit visits. So when you go to the home and supervise that care, that can kind of be twofold. You can be there supervising the care that they're providing and whether the patient's happy about it. And you can also be supervising or overseeing those skills. Knowledge-based situational case studies, those are usually like written examinations that you can provide, or a self-assessment tool was essentially which they grade themselves on whether they think or how well they think they're competent in that area. We say that a self-assessment tool alone should not be accepted or would not be acceptable for our standards. So if you are issuing a self-assessment tool, you would need to actually assess them in a different means, a second means at least, than just doing the self-assessment alone. Because more times than not, how many times is a person going to say, "Oh yeah, I'm not great. I'm not that great at this skill." So there are things you would catch that where you're actually providing an assessment on top of just the self-assessment. So tips here are going to be ensure you have a competency assessment developed for each of the services you offer. So whether that's companion, aid, nursing, any of the therapies, social services, all those should be, providing skills that get assessed. Now, when it comes to the G tags for Medicare, there are G tags tied and related to the aid services. So those are important that you address those as Medicare outlines them. For the rest of the services, it's left up to you how that assessment is, what it looks like, how it's handled. For our aids, Medicare actually does say that there's certain things that does have to be observed as being performed on a patient. So you need to be aware of what that looks like, because things like baths, shampooing, those are things that actually do have to be performed on an actual person. So those are going to be things we look for based on your assessments. Make sure it's documented as being complete. So the assessment is complete in its entirety. If there are skills not available, simply note that on the competency, that the skill was not present at the time in order to assess the individual for it. So those are okay as long as we're not seeing that that skill is being performed as part of the care, but it is okay to not necessarily assess them for everything at onboarding. But when they do need to go do it, so they do have a new task added, then you will then add that at that time. And then making sure you're doing a competency annually. Again, ensure you're not using a self-assessment tool alone, that you're using to verify those competencies. You're using it in conjunction with something else, like a case study or, shadowing them with a supervisory visit. Ensure that the clinical competencies are being done by like disciplines. So an RN can do an RN can do an LPN, an RN can do an aide. An RN could probably even do a social worker if you have that outlined in your policy. But an RN should not be doing like a PT. Those are different type of skill set. And so you really should have PT doing PT, PTAs, OTs doing OTs and CODAs. So make sure it makes sense because they are assessing the actual skill. It's not a performance. We have other requirements that talk about performance, and then that's where the clinical manager role can, assess for that. But this is for the skills, the actual skills of the discipline. And then ensure plans that are in place for addressing any performance or that is not being met. So let's say a competency is not being met, then we'll want to see some kind of either retraining or re-education that was done with that individual in order to get them up to that competent level for that certain skill. And so make sure that you're documenting any kind of addressing of those performance measures that aren't being met and any kind of competencing of them. So after, let's say they didn't meet the skill, you've retaught them, you did visits with them, and then you reassess them. So you did re-competency them later down the road before you kind of let them go. All right, tuberculosis screening. So this has always kind of been a back and forth of what the requirement understanding is. I can tell you what ours is, but you will always need to look at what your AO requires. When it comes to our requirement, it's pretty lenient. We just require a baseline for TB testing for your field staff, because those are the ones that are going to be having direct patient contact at some point in time. So when you hire someone, you ask them for a baseline. That baseline can be from 12 months ago. That could be from 12 years ago. It really doesn't matter because the baseline has already, been done and completed and said whether they had TB at the time or not. And so that baseline for us would need to be a PPD skin test or blood test. A chest x-ray would not be acceptable for a baseline. Now, once you have that, let's say it is 12 years old that they're giving it to you. The reason we allow for that is because then you are going to provide an assessment screening at the time of hire then. So you would provide an assessment screening where they're actually indicating, are they showing symptoms or having evidence of symptoms of TB at the real time, here and now. If they are, then that's when you can send them to be reevaluated by a healthcare professional and be cleared to be able to see patients. But there is no need anymore to have repeat chest x-ray being done. That's where the symptom check to evaluation takes place of that. So again, it's also knowing your policy. There are some states that do have more stringent requirements out there. Like they say they only want it, only 12 months, it can't be more than 12 months old, or it has to be closer to the time of hire. But you need to know what your policy says, because if your policy says that you're going to do it within 3 months of hire, then we're going to hold you to that. So knowing what your policy says and following that is important. We also then require organizations to conduct an annual risk assessment to determine what kind of repeat testing you're going to do moving forward. So we leave that up to you. CMS doesn't, like I said, have any TB requirements, so it would be falling on your state and what your policy says. But we would leave that up to you as far as, do you want to just do a symptom evaluation every year? Or do you want everyone to have the PPD or blood tests? So you need to look at and be mindful of what your policy says, because if that's what's in your policy, then that's what we're going to hold you to. So verifying that your policy, what it states as far as TB screening for initial screening. So that would be your baseline at time of hire and any repeat screening. Make sure you're following your policy. Make sure you have evidence of having that baseline test and the symptom evaluation before the clinician goes out and sees the patients. And so make sure that that is evident, like I said, based on your policy. And then ensure that you're conducting an annual risk assessment, determining, what kind of testing you're going to be doing moving forward. All right, annual direct observation visit. So this is where you're actually having a supervisor go to the home to watch the care being performed while it's being performed. So we have supervisory visits that we follow in home health and home care, and those can vary based on discipline. This can be done in conjunction with a soup visit. So if you do want to do it, that's fine. It's just more times than not, supervisory visits, the supervisor goes to the home, they're asking the patient if they're happy with the services. It's kind of more of a satisfaction type supervision. And so think of this as you're actually assessing the care being performed. Because the soup visits, usually the person you're supervising doesn't necessarily have to be there. So you don't have to necessarily coordinate that happening at the same time. This you do. This you have to coordinate when care is actually being performed by that aide or by that, therapy assistant, and you're seeing the care being performed in live time. So once a year, you do have to do a direct observation visit. This is also a CMS requirement when it comes to the aid. You have to show that a direct observation once a year was done while they were there. And so just making sure, oftentimes it's the documentation that we see is deficient, that they're not documenting that the individual was present. We documented that the supervisor went to the home and they completed the assessment, or the form, but there was no evidence of the person that was being supervised was present. So making sure that it is clear in your documentation that both individuals or both parties were there. And so, like I said, you can do that in conjunction with a supervisory visit. Obviously, supervisory visit goes into the patient record because you're supervising the services, and you're only doing one for that service. So let's say you have two different aides going in providing care to a patient, you only need to do one supervisory visit in relation to that, because it's only one aid service, versus the annual direct observation. That is the individual that's providing the care. So that's going to be an assessment that gets completed and gets filed in the personnel record. And therefore you have to do two. If you had two aides, you had to do two direct observation visits because you have two different individuals you're observing care for. So very different on what your documentation needs to entail and in what record. All right, and then the last two they do cross over with the patient record, but like I said, a lot of this stuff is more back office, because typically you guys are the ones in the office filling out things like charges, so things for the consent. So these are both consent related. This one is for the financial agreement or financial consent that you have the patient sign. So making sure you're advising the patient orally and in writing. So you should have a written agreement or consent they're signing, but it should also be documented in the record that you advise this to them verbally as well. So make sure that that is being done. But these are things that, like charges, is centered a lot that gets missed. We're not completing charges for care. We have to notify the patient of the charges at the time that we're either doing that initial assessment or before. And agencies are different on how they, handle that. Some like to have someone administratively call them over the phone and go over those charges with them before, let's say, the clinician gets out there. Some send a administrative person out there with the clinician. Some send them out before. All as long as it's being done before that care or at the time that care is started, communicating that information and that the patient signed an agreement or consent acknowledging the charges, even if no charges are due. Let's say, especially for traditional Medicare, they don't have anything that's due. You still need to be filling out those consents with, no charge or $0 or however you have your consent or financial agreement set up. Don't just leave it blank. And so making sure that those are being completed in their entirety and in a written form. If charges change, then you have to also provide written notice of when those charges change. Let's say they change insurances, that's gonna take signing a new financial agreement. So ensure that staff can explain how patients are educated on their charges. So if we were to ask as a surveyor, clinician, how do you explain charges or how charges portrayed to the client, they should be able to disclose that or answer that question appropriately, especially if they are one of the admitting staff. Ensure that there's documentation that there's proof that the patient did receive that information. So some kind of signed copy in the clinical record. This is also interviewing questions we ask when we go do a home visit to patients is, did you receive or were you notified of the charges for your care? And then make sure that patients can state that they had been notified. So, or they have a copy in their home record. All right, and then the last one is patient rights. So this has to do with that patient rights statement that we all receive anytime we go to get health care, whether you're in a doctor's office, the hospital. Same thing happens with home health. You need to have a rights statement. Make sure the rights statement is all encompassing of everything that needs to be on there. So that's usually where we see issues with the rights statement is there was a right missing. Because you have to look at what CMS wants you to disclose, what your AO may want you to disclose, and what your state may have as far as requirements to disclose. Sometimes they have crossover, sometimes they don't. So making sure that you do have a right statement though that is all encompassing, that the patient's going to sign. This is something that the patient, you actually have to have them sign acknowledging they received it, or a legal representative if they're not able to sign for themselves. And then you also need to provide training to personnel regarding the rights that they have to adhere to. We need to make sure that they're in a manner or language that the patient understands. So if they have a different preferred native language, make sure that you can get that translated or transcribed for them. So looking at your rights statement, I would say once a year at least, just to make sure nothing has been revised from, like I said, accreditation, CMS, or your state level as far as any additional rights that they want disclosed. And these are things like they have the rights to, accept or refuse care. They have the rights to the service, being aware of the services that are going to be provided, to, the charges that the care is going to cost. So making sure that those are getting disclosed. Ensure that there's document evidence that the patient signed for it, they received a copy that they understand during that initial evaluation or just prior to. Make sure that your personnel have been receiving training. So we would look for evidence of in-services being provided annually regarding patient rights. And then they should be able to state some rights. So those are things we ask as surveyors is, can you state a couple of rights, patient rights to me? How can they follow and implement them if they don't know? We're not going to require them to state the whole right statement, but they should be able to state a couple just off the top of their heads. All right, so focus areas would be to document. The biggest areas that why we see these deficiencies is because they didn't document it. They tell us after the fact when we find it and point it out verbally, but that's not going to be acting as proof. So those of you that may be on the call that are nurses, we learned in nursing school, if it wasn't documented, it wasn't done. Same applies to any of this. We have to have that documented proof, and it has to be in there by the time we start survey. So if you're auditing internally and you're finding that it's not clear, or it wouldn't be clear if someone from the outside world, from the public came in, because that's what surveyors are, then it's not going to be clear to the surveyor. So make sure that you have it documented. Develop tools that you can use in order to audit for these areas. Implement them when you're finding deficiencies. Implement a plan of correction that you can put into place to fix that moving forward. Because more times than not, it's not just you can sweep it under the rug and the surveyor, maybe they find it, maybe they don't. More times than not, we will. So it's a matter of acknowledging, you had an area of concern, or you had an area that was, out of compliance. And this is what you did to fix it. And now moving forward, this is no longer an issue. That's part of a performance or quality improvement plan. So if you do that and you put that in place, those are things you want to share with your surveyor because, like I said, more likely than not, he or she's going to find it. And then what? If we haven't seen that you fixed it or you put anything to resolve it, then it's still going to be a deficiency. Rather, if you did fix it and it's not longer a being issue, then you're in current compliance because we're going to grade you on current compliance, not necessarily if it happened months ago and it's now no longer being an issue. All right. So we can stop and see if we had any questions. Leslie, are you there? I know she was having internet issues, so I don't see any questions. Oh, there's one. During initial survey, do I need to have OASIS assessments? If you're going for Medicare, yes, that is a requirement that you have the OASIS completed as well for that initial survey. Now you won't transmit them. You don't need to transmit them because you don't have the ability to yet, but you at least need to perform them and complete them. All right, I'm not seeing any other questions. So if you do have questions though, there's our contact information. You're more than welcome to reach out to us. If you're a current client, you should have already been assigned an account advisor. So I would start with them. But if you're new or just have general questions that you want answered, there's our contact information. Or you can reach out to Leslie and she can always get with me. I can help answer anything that I can. Otherwise, I will let you guys go for the afternoon. All right, a couple of questions just popped in out. So do you need to have clients beforehand? Yes, you do. So depending on what program you're going for, if you're going for Medicare and this is your initial, you need to have served 10 clients. For home care, it's 5. Why don't you take TB X-ray? Again, because X-ray does not show a baseline of TB. So per the CDC, it has to be a PPD skin test or blood test. So we would not take it as a baseline, but we could take it as any kind of retesting if that's what your policy says. So if they're people that typically do an X-ray because they are coming back positive with PPD, then they would do the blood test. All right, someone's asking about cost. That varies by accreditation. So and I don't do sales. So that's something you could contact us at this number here and they can talk to you about costs because it does vary by different things. All right, well, I'm going to let you guys go. I hope you have a great rest of your day and thanks for attending.